The Management of Ovarian Cysts in Postmenopausal Women, Green Top Guideline number 34, July 2016. Introduction and Background Epidemiology. Ovarian cysts are common in postmenopausal women. The exact prevalence is unknown given the limited amount of published data and the lack of established screening programs for ovarian cancer. However, studies have estimated the incidence to be anywhere between 5% and 17%. The greater use of ultrasound in gynecological practice and the widespread generalized use of other imaging techniques such as computed tomography, CT, and magnetic resonance imaging or MRI mean that an increasing proportion of the cysts will be found incidentally. However, cystic lesions in the postmenopausal ovary should only be reported as ovarian cysts and considered significant if they are 1 centimeter or more in size. Cystic lesions smaller than 1 centimeter are clinically inconsequential, and it is at the discretion of the reporting clinician whether or not to describe them in the imaging report, as they do not need follow-up. The vast majority of these identified cysts are benign. Therefore, the underlying management rationale is to distinguish between those cysts that are benign and those that are potentially malignant. Diagnosis and significance of ovarian cysts in postmenopausal women. How are ovarian cysts diagnosed in postmenopausal women, and what initial investigations should be performed? Clinicians should be aware of the different presentations and significance of ovarian cysts in postmenopausal women. In postmenopausal women presenting with acute abdominal pain, the diagnosis of an ovarian cyst accident should be considered, for example, torsion, rupture, and hemorrhage. It is recommended that ovarian cysts in postmenopausal women should be initially assessed by measuring serum cancer antigen 125 or CA125 level and transvaginal ultrasound scan. Ovarian cysts in postmenopausal women could present in one of 3 ways. Some women present with acute pain, for example, torsion or rupture of a cyst, requiring immediate evaluation. Other women have their ovarian cysts identified during gynecological investigations, for example, for postmenopausal bleeding. Finally, some ovarian cysts are found incidentally in postmenopausal women undergoing investigations by other specialties for non-gynecological conditions, for example, cross-sectional imaging for general surgical or medical indications. In order to triage women and guide further management, an estimate needs to be made as to the risk that the ovarian cyst is malignant. At present, the recommended tests are serum CA125 measurement and pelvic ultrasound. The anxiety and concerns for the possibility of ovarian cancer and the women's understandable fear of malignancy should not be underestimated. The rationale behind and the limitations of any recommended test should be clearly and sensitively communicated to the women with an explanation of the results. where the initial imaging modality was a CT scan, unless this clearly indicated ovarian malignancy and widespread intra-abdominal disease. An ultrasound scan should be obtained in order to calculate the risk of malignancy index or RMI. What is the role of history and clinical examination in postmenopausal women with ovarian cysts? A thorough medical history should be taken from the women with specific attention to risk factors and symptoms suggestive of ovarian malignancy and a family history of ovarian, bowel, or breast cancer. Where family history is significant, referral to the Regional Cancer Genetics Service should be considered. Appropriate tests should be carried out in any postmenopausal woman who has developed symptoms within the last 12 months that suggest irritable bowel syndrome, particularly in women over 50 years of age or those with a significant family history of ovarian, bowel, or breast cancer. A full physical examination of the woman is essential and should include body mass index or BMI, abdominal examination to detect ascites, and characterize any palpable mass, and vaginal examination. Family history can be used to define women who are at increased risk of ovarian cancer. A woman is defined as being at higher risk of ovarian cancer if she has a first-degree relative like mother, father, sister, brother, daughter, or son affected by cancer within a family with two or more individuals with ovarian cancer who are first-degree relatives of each other. One individual with ovarian cancer at any age, and one with breast cancer diagnosed under age 50 years, who are first degree relatives of each other. One relative with ovarian cancer at any age, and two with breast cancer diagnosed under age 60 years, who are connected by first degree relationships. Three or more family members with colon cancer, or two with colon cancer, and one with stomach, ovarian, endometrial, urinary tract, or small bowel cancer in 2 generations. One of these cancers must be diagnosed under age 50 years, and affected relatives should be first degree relatives of each other. One individual with both breast and ovarian cancer. A woman is also considered at increased risk of ovarian cancer if she is a known carrier of relevant cancer gene mutations, for example, BRCA1, BRCA2, and mismatch repair genes. She is an untested first degree relative of an individual with a relevant cancer gene mutation, or she is an untested second degree relative through an unaffected man of an individual with a relevant cancer gene mutation. Where family history is significant, referring the woman to the Regional Cancer Genetics Service should be considered. Ovarian cancer often presents with vague abdominal symptoms that are widely experienced among the general population: persistent abdominal distension, feeling full and or loss of appetite, pelvic or abdominal pain, increase urinary urgency and/or frequency. Therefore, the challenge is to make the correct diagnosis as early as possible, despite the non-specific nature of symptoms and signs, and various indices have been developed to triage women for further investigations and correlate symptoms to the likelihood of ovarian cancer, for example, the Goff Symptom Index. The symptoms described have greater significance in postmenopausal women, particularly over 50 years of age, if experienced persistently or on a frequent basis, or in those with a significant family history, two or more cases of ovarian or breast cancer diagnosed at an early age in first-degree relatives. Although clinical examination has poor sensitivity in the detection of ovarian masses, 15 to 51%, its importance lies in the evaluation of any palpable mass for tenderness, mobility, nodularity, and ascites. Pelvic examinations, including a rectal exam, even under anesthesia, have shown limited ability to identify an adnexal mass, especially with increasing patient body mass index greater than 30. Nevertheless, features most consistently associated with an adnexal malignancy include a mass that is irregular, has a solid consistency, is fixed, nodular or bilateral, or is associated with ascites. Postmenopausal women should be urgently referred to specialist services if physical examination identifies ascites and/or a pelvic or abdominal mass. What blood tests should be performed in postmenopausal women with ovarian cysts? CA125. CA125 should be the only serum tumor marker used for primary evaluation as it allows the RMI or risk of malignancy index of ovarian cysts in postmenopausal women to be calculated. CA125 levels should not be used in isolation to determine if a cyst is malignant. While a very high value may assist in reaching the diagnosis, a normal value does not exclude ovarian cancer due to the non-specific nature of the test. The use of serum CA125 is well established, being raised in over 80% of epithelial ovarian cancer cases, but not in most primary mucinous ovarian cancers. If a cutoff of 30 international unit per ml is used, the test has a sensitivity of 81% and a specificity of 75%. However, CA125 values can show wide variation with lower levels equivalent to 20 international unit per ml found in healthy postmenopausal women. Non-malignant gynecological conditions such as pelvic inflammatory disease, fibroids, acute events in benign cysts, for example torsion or hemorrhage, and endometriosis can all result in an increased CA125 level. Higher values are reported in Caucasian compared with African or Asian women. Caffeine intake, hysterectomy, and smoking have been associated with lower CA125 levels in some reports. Numerous benign non-gynecological conditions that cause peritoneal irritation, such as tuberculosis, cirrhosis, ascites, hepatitis, pancreatitis, peritonitis, and pleuritis, and other primary tumors that metastasize to the peritoneum, such as breast, pancreas, lung, and colon cancer, can also cause an elevated CA125. CA125 alone has a pooled sensitivity and specificity of 78% for differentiating benign from malignant adnexal masses, with higher values noted in postmenopausal women. Other tumor markers. There is currently not enough evidence to support the routine clinical use of other tumor markers such as human epididymis protein 4 or HE4, carcinoembryonic antigen or CEA, CDX2, cancer antigen 72-4, cancer antigen 19-9, alpha fetoprotein, lactate dehydrogenase or LDH, or beta-human chorionic gonadotrophin or beta-HCG to assess the risk of malignancy in postmenopausal ovarian cysts. HE4 or human epididymis protein 4. HE4 is a glycoprotein found in epididymal epithelium. Increased serum HE4 levels and expression of the HE4 or WFDC2 gene occurs in ovarian cancer as well as in lung, pancreas, breast, bladder, or urethral transitional cell and endometrial cancers. HE4 is not increased in endometriosis and has fewer false positive results with benign disease compared with CA125. There are some preliminary data suggesting that HE4 is more sensitive and specific than serum CA125 for the diagnosis of ovarian cancer. However, HE4 is not in routine clinical use, and the data on HE4 are not substantial enough to enable it to be recommended routinely instead of or in addition to serum CA125 at the time of writing of this guideline. Carcinoembryonic antigen or CEA, CDX2, cancer antigen 72-4 or CA72-4, cancer antigen 19-9 or CA19-9, alpha fetoprotein, lactate dehydrogenase or LDH, and beta-human chorionic gonadotrophin or beta-HCG. There is not enough evidence to suggest that panels including multiple tumor markers offer any further advantage in the initial assessment of ovarian cysts in postmenopausal women. All of these markers show low sensitivity and wide variation in specificity when used in isolation or in combination with CA125. What imaging should be employed in the assessment of ovarian cysts in postmenopausal women? What is the role of ultrasound scanning in categorizing cysts? A transvaginal pelvic ultrasound is the single most effective way of evaluating ovarian cysts in postmenopausal women. Transabdominal ultrasound should not be used in isolation. It should be used to provide supplementary information to transvaginal ultrasound particularly when an ovarian cyst is large or beyond the field of view of transvaginal ultrasound. On transvaginal scanning, the morphological description and subjective assessment of the ultrasound features should be clearly documented to allow calculation of the risk of malignancy. Transvaginal ultrasound scans should be performed using multi-frequency probes by trained clinicians with expertise in gynecological imaging. On transvaginal ultrasound, a simple cyst is associated with 5 features: round or oval shape, thin or imperceptible wall, posterior acoustic enhancement, anechoic fluid, and absence of septations or nodules. Characterization of an adnexal mass as a simple cyst is important for management. Ultrasound identification of a simple cyst establishes a benign process in 95 to 99% of postmenopausal women. An ovarian cyst is defined as complex in the presence of one or more features: complete septation, for example, multilocular cyst, solid nodules, and papillary projections. These are worrying features associated with an increased incidence of malignancy, 8% for multilocular and 36 to 39% for lesions with solid elements. A detailed ovarian cyst classification system has been developed by the consensus group from the International Ovarian Tumor Analysis or IOTA group. It is worth noting that this group included in their definition of a unilocular cyst minor inner abnormalities such as an incomplete septum or less than 3 millimeters papilla. Transabdominal and transvaginal scanning are complementary because of the improved resolution of transvaginal ultrasound. It should be used whenever possible and is recommended as a first-line imaging modality for assessing ovarian cysts in postmenopausal women. When an ovarian cyst is large or beyond the field of view of transvaginal sonography, transabdominal ultrasound is recommended. Subjective assessment by ultrasound remains valuable in discriminating malignant from benign ovarian masses. Pattern recognition of specific ultrasound findings with more complex scoring systems can produce sensitivity and specificity equivalent to logistic regression models. A study has shown that transvaginal ultrasound may help characterize benign and malignant cysts with a sensitivity of 89% and a specificity of 73% when using a morphology index. The findings, however, should be correlated with the history and laboratory tests. A more recent study has shown that use of a more specific gynecologic imaging reporting and data system or GI-RADS scoring may increase the sensitivity to 99.1% and specificity to 85.9%. In postmenopausal women, simple cysts are seen with a frequency of 5 to 17% and are not related to hormonal therapy or time since onset of menopause, although some have observed decreasing frequency with time after the onset of menopause. In a 2-year follow-up study of asymptomatic postmenopausal women with simple cysts smaller than 5 cm, these cysts were shown to disappear 53%, remain static 28%, enlarge 11%, decrease 3%, or fluctuate in size 6%. Evidence from larger screening studies found a higher rate of resolution of unilocular cysts at 70%, with only complex cysts having an increased risk of malignancy. Adnexal cysts 5 cm or smaller in postmenopausal women are rarely malignant. Postmenopausal ovarian cysts with a solid component include benign ovarian tumors such as samteratomas, cyst adenomas, cyst adenofibromas, malignant ovarian tumors, primary and metastatic, or a torted ovary. Although ultrasound may not unequivocally distinguish malignant from benign cyst, it provides useful information. The presence of mural nodules or septations, especially with vascular flow, suggests that the ovarian cyst is malignant. However, it is important to note that no single ultrasound finding differentiates categorically between benign and malignant ovarian masses. What is the role of Doppler and three-dimensional ultrasound studies? Color flow Doppler studies are not essential for the routine initial assessment of ovarian cysts in postmenopausal women. Spectral and pulse Doppler indices should not be used routinely. Resistive index, pulsatility index, peak systolic velocity, time average maximum velocity to differentiate benign from malignant ovarian cyst, as their use has not been associated with significant improvement in diagnostic accuracy over morphologic assessment by ultrasound scan. Three-dimensional ultrasound morphologic assessment does not appear to improve the diagnosis of complex ovarian cysts, and its routine use is not recommended in the assessment of postmenopausal ovarian cysts. Malignant masses generally demonstrate neovascularity with abnormal branching patterns or vessel morphology. These neovessels have lower resistance flow than native ovarian vessels. Hence, sonographic evaluation using a combination of morphologic assessment and color flow or power Doppler imaging to detect abnormal blood flow has been proposed to assess suspicious ovarian cysts for the risk of malignancy in some studies. The combined use of transvaginal ultrasound with power Doppler flow mapping has been shown in the research setting to improve sensitivity and specificity compared with the use of transvaginal ultrasound alone, particularly in complex cases. Such tests are not universally available and cannot be recommended for the routine initial assessment of ovarian cysts in postmenopausal women. What is the role of CT scan, MRI, and other cross-sectional imaging? CT, MRI, and positron emission tomography or PET CT scans are not recommended for the initial evaluation of ovarian cysts in postmenopausal women. Their initial routine use cannot yet be recommended. However, These additional imaging modalities may have a place in the evaluation of more complex lesions or in the setting of suspected metastatic spread. CT scan or computed tomography scan. CT should not be used routinely as a primary imaging tool for the initial assessment of ovarian cysts in postmenopausal women because of its low specificity, its limited assessment of ovarian internal morphology, and its use of ionizing radiation. If, from the clinical picture, ultrasonographic findings and tumor markers, malignant disease is suspected, a CT scan of the abdomen and pelvis should be arranged with onward referral to a gynecological oncology multidisciplinary team. Currently, the best use of CT imaging is not to detect and characterize pelvic masses, but to evaluate the abdomen for metastases when a malignant cyst is suspected based on transvaginal ultrasound images, examination, and serum markers. CT is useful in selected cases when a non-gynecologic origin of an adnexal cyst is suspected. For example, other non-gynecological retroperitoneal cystic masses. A CT scan can detect omental metastases, peritoneal implants, pelvic or para-aortic lymph node enlargement, hepatic metastasis, obstructive uropathy, and possibly an alternate primary cancer site, including pancreas or colon. CT scan may be indicated to stage a suspected primary ovarian cancer or to identify the primary intra-abdominal cancer, for example colon, gastric, and pancreatic, with suspected ovarian metastases. MRI or magnetic resonance imaging. MRI should not be used routinely as a primary imaging tool for the initial assessment of ovarian cysts in postmenopausal women. MRI should be used as a second-line imaging modality for the characterization of indeterminate ovarian cysts when ultrasound is inconclusive. While assessment with MRI can improve overall sensitivity and specificity of ovarian cyst characterization, there are inherent limitations to the more widespread use of MRI, which preclude its routine use over transvaginal ultrasonography. These are both institutional, for example, high cost, more restricted availability, and patient-related restrictions. MRI is contraindicated in certain patients, for example, with cardiac pacemaker, cochlear implants, and can have reduced acceptance by some patients, for example, those with claustrophobia. MRI should be considered for characterization of indeterminate adnexal cysts with identification of enhancing vegetations in cystic masses and the presence of ascites being the best indicators of malignancy. Further characterization by MRI is also of value where an alternative diagnosis to an ovarian neoplasm is thought more likely or if, anatomically, the ovarian origin of a pelvic cyst is in doubt. MRI is a valuable problem-solving tool when ultrasound is inconclusive or limited due to body habitus. MRI of the sonographically indeterminate adnexal mass can be used to guide patient care and reduce the costs of further management. Women who clinically have a low risk of malignancy but have complex lesions on ultrasound scan are the ones who will most likely benefit from contrast-enhanced MRI. A meta-analysis which compared the incremental value of a second test to evaluate an indeterminate adnexal mass on ultrasound found that contrast-enhanced MRI provided a greater certainty of ovarian cancer diagnosis compared with CT, Doppler ultrasound, or MRI without contrast. The documented major contribution of MRI in adnexal mass evaluation is its specificity, as it can provide a confident diagnosis of many benign adnexal lesions. Functional MR sequences such as diffusion-weighted imaging or DWI, together with its quantitative derivative, an apparent diffusion coefficient or ADC map, and dynamic contrast enhanced imaging can be added to conventional sequences. Positron emission tomography or PET CT scan. Current data do not support the routine use of PET CT scanning in the initial assessment of postmenopausal ovarian cysts. Data suggests there is no clear advantage over transvaginal ultrasonography. However, PET-CT may play a role in women with a known history of malignancy who present for evaluation of an adnexal mass to identify other sites of disease. Initial assessment and estimation of the risk of malignancy. Which RMI or risk of malignancy should be used? The RMI-1 is the most utilized, widely available, and validated effective triaging system for women with suspected ovarian cancer. Although a RMI-1 score with a threshold of 200, sensitivity 78%, specificity 87%, is recommended to predict the likelihood of ovarian cancer and to plan further management, some centers utilize an equally acceptable threshold of 250 with a lower sensitivity, 70%, but higher specificity, 90%. CT of the abdomen and pelvis should be performed for all postmenopausal women with ovarian cysts who have a RMI-1 score greater than or equal to 200, with onward referral to a gynecological oncology multidisciplinary team. It is recommended that a risk of malignancy index should be used to guide the management of postmenopausal women with ovarian cysts as an effective way of triaging these women into those who are at low or high risk of malignancy and who hence may be managed by a general gynecologist or in a cancer unit or cancer center. Calculation of the risk of malignancy index 1. The risk of malignancy index 1 combines three pre-surgical features. It is a product of the serum CA125 level, international units per ml, the menopausal status or M, and an ultrasound score or U as follows. RMI is equals to U, multiply by M multiply by CA125. The ultrasound result is scored 1 point for each of the following characteristics: multilocular cyst, solid areas, metastasis, ascites, and bilateral lesions. U is equals to 0 for an ultrasound score of 0. U is equals to 1 for an ultrasound score of 1. U is equals to 3 for an ultrasound score of 2 to 5. The menopausal status is scored as 1 equals to premenopausal and 3 equals to postmenopausal. Serum CA125 is measured international units per ml and can vary between 0 and hundreds or even thousands of units. Although a RMI threshold of 200 is recommended, benign conditions may cause elevation of the RMI score and early malignancy may not. Those women who are at low risk of malignancy also need to be triaged into those where the risk of malignancy is sufficiently low to allow conservative management and those who still require intervention of some form. When ovarian malignancy is considered likely based on clinical assessment and a RMI 1 score greater than or equal to the threshold of 200, cross-sectional imaging in secondary care in the form of a CT scan of the abdomen and pelvis is indicated to help assess the extent of disease and to help exclude alternative diagnosis with onward referral to a gynecological oncology multidisciplinary team. Clinical acumen has to be used to decide on further appropriate management of the women, including the location of prospective surgery. No currently available tests are perfect, offering 100% specificity and sensitivity. However, women could be counseled that RMI scores of less than 25, between 25 and 250, and greater than 250 carry a risk of cancer of less than 3%, around 20%, and around 75% respectively, based on historical validation data. Although most ovarian cysts in postmenopausal women will be benign, a higher cutoff score, for example 250, could mean that some women who did have ovarian cancer would not be identified nor referred for specialist treatment under a gynecological oncologist care, possibly compromising their outcomes. In light of the existing best evidence in literature, a RMI 1 cutoff value of 200 to initiate a CT scan and onward referral to a gynecological oncology multidisciplinary team meeting for further evaluation should be recommended. What other scoring systems are available and when should they be used? Other scoring systems are described: OVA1 or OVA1 and risk malignancy algorithm or ROMA require specific assays which make routine use impractical. The IOTA classification, which is based on a specific ultrasound expertise, has comparable sensitivity and specificity to RMI and forms an alternative for those experienced in this technique. IOTA or International Ovarian Tumor Analysis Group Simple Ultrasound Rules and Logistic Regression Model LR2. Simple ultrasound rules were derived from the IOTA group data to help classify masses as benign, B rules, or malignant M rules. Using these morphological rules, the reported sensitivity was 95% and the specificity was 91%, with a positive likelihood ratio of 10.37 and a negative likelihood ratio of 0.06. Women with an ovarian mass with any of the M rules ultrasound findings should be referred to a gynecological oncology service. If the ovarian cysts are not clearly classifiable from these rules, further investigation by a specialist in gynecological ultrasound is appropriate. Triaging women using the IOTA Logistic Regression Model LR2, a 6-variable prediction model, has been proposed as an alternative to RMI-based protocols, with the suggestion that the IOTA protocol may avoid major surgery for more women with benign cyst, while still appropriately referring more women with a malignant cyst to a gynecological oncologist. Data about the use of LR2 are still emerging, and it cannot be recommended for routine clinical use as yet. Table number 1. IOTA Group Simple Ultrasound Rules. B rules. Unilocular cyst, presence of solid components where the largest solid component is less than 7 mm, presence of acoustic shadowing, smooth multilocular tumor with largest diameter less than 100 mm, and no blood flow on color Doppler. M rules. Irregular solid tumor, ascites, at least 4 papillary structures, irregular multilocular solid tumor with largest diameter of greater than or equal to 100 mm, and prominent blood flow on color Doppler. Risk of malignancy algorithm or ROMA. ROMA is a quantitative test using CA125, HE4 concentration, and menopausal status to calculate the risk of ovarian cancer. A numerical score is obtained based on an algorithmic equation calculation with a cutoff value of 2.27, representing a high risk of malignancy. ROMA calculation requires the use of special assays for CA125 and HE4. Overall, it has a sensitivity of 89% and a specificity of 75%. Although ROMA is promising for distinguishing epithelial ovarian cancer from benign ovarian cyst, HE4 is not in routine clinical use, and the data on HE4 are not substantial enough to recommend its routine use instead of or in addition to serum CA125 at the time of writing of this guideline. OVA1. OVA1 is a quantitative assay measuring 5 serum proteins, CA125, transthyretin, prealbumin, apolipoprotein A1, beta-2 microglobulin, and transferrin, and combining them into a numerical score. Although OVA1 has a high sensitivity, it shows a lower specificity and positive predictive value than the RMI. How do you manage ovarian cysts in postmenopausal women? What are the different management options and eligibility criteria? The clinician must try to differentiate cysts that are most likely to be benign from those that are likely to be malignant based on the clinical assessment and RMI. A decision can then be made regarding the most appropriate management options. Cysts with low likelihood of malignancy can often be managed conservatively. Selected cases with a RMI of less than 200 can be managed surgically by laparoscopic salpingo-oophorectomy after discussion with the patient. Conversely, those cysts that are likely to be malignant are best managed with further imaging in the form of a CT scan and referral to a gynecological oncologist. Do all postmenopausal women with ovarian cysts require surgical evaluation, and is there a role for conservative management? Asymptomatic, simple, unilateral, unilocular ovarian cysts less than 5 cm in diameter have a low risk of malignancy. In the presence of normal serum CA1 to 5 levels, this cyst can be managed conservatively with a repeat evaluation in 4 to 6 months. It is reasonable to discharge these women from follow-up after 1 year if the cyst remains unchanged or reduces in size, with normal CA1 to 5 taking into consideration a woman's wishes and surgical fitness. If a woman is symptomatic, further surgical evaluation is necessary. A woman with a suspicious or persistent complex adnexal mass needs surgical evaluation. Clinicians should discuss the pros and cons of conservative versus surgical management in women at low risk of malignancy or RMI 1 less than 200. The risk of malignancy in these studies of simple cysts that are less than 5 cm, unilateral, unilocular, and echo-free with no solid parts or papillary formation is less than 1%. In addition, a study reported that more than 50% of these simple cysts might resolve spontaneously within 3 months. It is reasonable to manage the simple cyst conservatively with a follow-up assessment of serum CA1 to 5 and a repeat ultrasound scan. A reasonable proposed interval is 4 to 6 months. This, of course, depends upon the views and symptoms of the woman, her surgical fitness, and on the clinical assessment. Some women requiring surgical intervention are at substantial risk of perioperative morbidity and mortality. In such instances, repeat imaging often safer than immediate operative intervention, although the frequency of repeat imaging has not been determined. What are the available surgical options? Women who do not fit the criteria for conservative management should be offered surgical treatment in the most suitable location and set up by the most suitable surgeon as determined by the RMI. Initial surgical management options that have been assessed include imaging-guided aspiration of the cyst, laparoscopy, and laparotomy. What is the role of aspiration of ovarian cysts in postmenopausal women? Aspiration is not recommended for the management of ovarian cysts in postmenopausal women except for the purposes of symptom control in women with advanced malignancy who are unfit to undergo surgery or further intervention. Aspiration of an ovarian cyst in a postmenopausal woman is not recommended. Firstly, Diagnostic cytological examination of ovarian cyst fluid is poor at distinguishing between benign and malignant tumors, with sensitivities in most studies of around 25%. In addition, even when a benign cyst is aspirated, the procedure is often not therapeutic. Approximately 25% of cysts in postmenopausal women will recur within 1 year of the procedure. Finally, aspiration of a malignant cyst may induce spillage and seeding of cancer cells into the peritoneal cavity, thereby adversely affecting the stage and prognosis. There have been many cases of aspirated malignant masses recurring along the needle track through which the aspiration was done. Furthermore, there is strong evidence that spillage from a malignant cyst has an unfavorable impact on overall and disease-free survival of stage 1 cancer patients compared with patients from whom tumors have been removed intact. Aspiration, therefore, has no role in the management of asymptomatic ovarian cyst in postmenopausal women. An exception exists for those symptomatic women who are medically unfit to undergo surgery or further intervention. In these women, aspiration will provide relief of their symptoms, albeit temporarily. Could postmenopausal ovarian cysts be managed by laparoscopy? Women with an RMI-1 of less than 200, for example at low risk of malignancy, are suitable for laparoscopic management. Laparoscopic management of ovarian cysts in postmenopausal women should be undertaken by a surgeon with suitable experience. Laparoscopic management of ovarian cysts in postmenopausal women should comprise bilateral salpingo-oophorectomy rather than cystectomy. Women undergoing laparoscopic salpingo-oophorectomy should be counseled preoperatively that a full staging laparotomy will be required if evidence of malignancy is revealed. Where possible, the surgical specimen should be removed without intraperitoneal spillage in a laparoscopic retrieval bag via the umbilical port. This results in less post-operative pain and a quicker retrieval time than when using lateral ports of the same size. The transvaginal extraction of the specimen is also acceptable if the surgeon has the available expertise. A suitably experienced surgeon may operate laparoscopically on women who fall below the RMI-1 cutoff of less than 200. In postmenopausal women, the appropriate laparoscopic treatment for an ovarian cyst that is not suited for conservative management is salpingo-oophorectomy with removal of the ovary intact in a retrieval bag without cyst rupture into the peritoneal cavity. This is the case even when the risk of malignancy is low. In most cases, this is likely to be a bilateral salpingo-oophorectomy, but this will be determined by the wishes of the woman. The decision to remove both ovaries should be undertaken following discussion with the woman. There is the risk of cyst rupture during cystectomy. Cyst rupture into the peritoneal cavity may have an unfavorable impact on disease-free survival in the small proportion of cases with an ovarian cancer. If evidence of malignancy is revealed during the operation or at final histology, women should be made aware that a full staging laparotomy will be required. Removal of benign ovarian masses via the umbilical port should be utilized where possible, as this results in less post-operative pain and a quicker retrieval time. Avoidance of extending accessory ports is beneficial in reducing postoperative pain as well as reducing incidence of incisional hernia and incidence of epigastric vessel injury. It also leads to improved cosmesis. A transvaginal approach for specimen removal after laparoscopic resection of adnexal masses has been found to offer some advantage in terms of post-operative pain compared with transumbilical retrieval. In experienced hands, transvaginal specimen retrieval after operative laparoscopy represents a safe, feasible, and applicable technique. When should laparotomy be undertaken? All ovarian cysts that are suspicious of malignancy in a postmenopausal woman, as indicated by a RMI1 greater than or equal to 200, CT findings, clinical assessment, or findings at laparoscopy, require a full laparotomy and staging procedure. If a malignancy is revealed during laparoscopy or from subsequent histology, it is recommended that the woman be referred to a cancer center for further management. Women who are at high risk of malignancy, as calculated using the RMI greater than or equal to 200, are likely to need a laparotomy and full staging procedure as their primary surgery. In addition to the calculated risk of malignancy, other factors such as any other medical conditions affecting the risk of surgery will affect the decision as to whether a woman is able to undergo surgery, what type of surgery is performed, and where this takes place. If an ovarian cancer is discovered during laparoscopic surgery or on histology, a subsequent full staging procedure is likely to be required. Secondary surgery should be performed as soon as feasible. It is important to consider borderline ovarian tumors as a histological diagnosis when undertaking any surgery for ovarian masses. When such a histological diagnosis is made or strongly suspected, referral to a gynecological oncology center is recommended. Preoperative diagnosis can be difficult, with radiological and serum markers being relatively insensitive, especially in their differentiation from stage 1 ovarian epithelial cancers. Although up to 20% of borderline ovarian tumors appear as simple cysts in ultrasonography, the majority of such tumors will have suspicious ultrasonographic finding. The staging laparotomy should ideally be performed through a midline incision by an appropriately trained surgeon working as part of a multidisciplinary team in a cancer center and should include laparotomy with clear documentation, cytology, ascites or washings, total abdominal hysterectomy, bilateral salpingo-oophorectomy, and omentectomy, and biopsies from any suspicious areas. The laparotomy and staging procedure may include bilateral selective pelvic and para-aortic lymphadenectomy. Where should postmenopausal women with ovarian cysts be managed? The appropriate location for the management should reflect the structure of cancer care in the UK. Mean survival time for women with ovarian malignancy is significantly improved when managed within a specialist gynecological oncology service. Hence, early diagnosis and referral is important. As the risk of malignancy increases, the appropriate location for management changes. Therefore, while women with a low risk of malignancy or an RMI-1 less than 200 may be managed in a general gynecology or cancer unit, those who are at high risk, RMI-1 greater than or equal to 200, and suspicious CT findings should be discussed by a multidisciplinary team. Who should manage ovarian cysts in postmenopausal women? While a general gynecologist might manage women with a low risk of malignancy, RMI-1 less than 200, in a general gynecology or cancer unit, women who are at higher risk should be managed in a cancer center by a trained gynecological oncologist unless the multidisciplinary team review is not supportive of a high probability of ovarian malignancy. The prognosis for women with ovarian cancer is improved when the entire tumor is removed at surgery. Optimal surgical cytoreduction and appropriate staging is more likely to be achieved by a trained gynecological oncologist in a cancer center setting. Women need to be triaged so that a gynecological oncologist in a cancer center operates on those women with an elevated RMI where the multidisciplinary team review is supportive of a high risk of ovarian malignancy. When the RMI is elevated, but the multidisciplinary team review is not suggestive of ovarian malignancy, a lead clinician in a cancer unit can perform the surgery. Women at low risk may be operated on by a general gynecologist or offered conservative management. The high specificity and sensitivity of the RMI-1 makes it an ideal and simple way of triaging women for this purpose. Appendix number 2. Clinical algorithm for the management of postmenopausal women with ovarian cyst.